Hello, welcome to the GE MSK webinar series. Today, myself, Daniel Walkley, and my colleague Matthew Goulet will be talking about a focus on the shoulder. So we will talk about how we go about assessing the rotator cuff tendons with ultrasound and joint assessment, along with the interventional techniques that we use. The majority of the images that I'll be presenting today have been acquired using the Venue Go. The Venue is a family of point of care units comprising of 3 different systems over one platform. The Venue family of systems was made for musculoskeletal practitioners who need to assess tendons, muscles and joints. And we've been lucky enough to be able to use the L4-20T linear probe, their high frequency linear probe. So you'll see quite a few cases using this equipment today. So first of all, I want to talk about how the rotator cuff, it really is a true confluent cuff. We've got our subscapularis, our supraspinatus and our infraspinatus forming this true overarching band of collagen, and posteriorly the infraspinatus and teres minor blending around together to form this true rotator cuff. It's a blending, it's an interdigitation of fibers. It's not one tendon abutting another one, it's this true interdigitation. And we'll talk about that and we'll express how we see that and how we investigate these areas. The other thing that I want you to be aware of with our talk today is not only are there tendinous origins going along, but there's also capsular origins underneath. So your supra, your infra, your subscapularis are all connected by the underlying joint capsule and the capsular ligaments that go around and envelop around the long-headed biceps tendon. So the first thing I'm going to talk about today is the long-headed biceps. In a minute I'll talk about the scan technique, the way we look from in short axis and long axis, how we assess down to the musculotendinous junction and all the way back up to the rotator interval as high as we can get. And we can see a significant amount of pathology that can occur. We can see tendinopathy of a tendon, we can see biceps sheath effusions, we can see tenosynovitis, we assess for long-headed biceps for tendon rupture, and we assess for subluxation. So we assess not only the tendon but the supporting structures that go around to help elongate the long-headed biceps tendon, and it's a bit of a window into what's happening with the joint. And we'll talk about that in a minute. So the biceps origin. The biceps origin is just beyond what we can see sonographically. It'd be lovely if we could confidently see and determine slap lesions, but we can't. We get very, very close, but we can't quite see that origin. Because the origin is both from the superior glenoid and part of the labrum. The long-headed biceps, it's an intracapsular tendon and takes part of the joint synovium through the interval to the level of the bicipital groove, meaning that it's an extension of the joint cavity. An injury to the superior labrum, such as slap tears, are often contiguous. The pathology is contiguous with the long-headed biceps. And this is a really nice quote that I'm taking from Richard Collins, a sports physician in the UK, of the bicipitolabral complex. We should be thinking of this as a bicipitolabral complex. It's not just a labral issue, it's not just a slap issue, it's not just a tendinopathy, it's a bicipitolabral complex where we have pathology spreading between the two entities. So when we have a look at our long-headed biceps tendon here, this is an image of a pathological long-headed biceps. And it looks like any other tendon on ultrasound that's pathological. It's swollen, it's enlarged, it's hypoechoic. You see the splitting of the fascicles. And we follow it down to it starts to normalize a little bit down in through here. So we see a gross enlargement of that tendon. So the tendinopathy occurs in multiple areas, but usually it occurs up towards the rotator interval. And the thing I want you to be aware of is that if you have a small amount of fluid around your long-headed biceps, or even a large amount of fluid around your long-headed biceps, very rarely is this tenosynovitis. More commonly, this is an extension of the underlying joint and underlying joint pathology. So tenosynovitis is very, very rare as an isolated entity. It's more likely to be coming from a joint. So a small amount of fluid around the long-headed biceps, remembering that the long-headed biceps is contiguous with the glenohumeral joint, is a small joint effusion. These can be small, these can be large, So we've got a large joint of fusion. We follow our long-headed biceps, and the intra-articular portion, the area up within the interval, becomes quite tendinopathic. So we know that we have the intra-articular tendon component of the long-headed biceps is abnormal, and we have a large fusion around it. So we know underlying this joint is probably unhappy. This extension of the joint, you can have synovitis, you can have loose bodies within your long-headed biceps. So these are extra-articular loose bodies. The long-headed biceps can tear, and sometimes you have a look in the sheath and you go, is there a small amount of fibres in through there? If you can't see good collagen tissue, there's not. Follow it down towards the musculotendinous junction, and you see the textbook atrophy of the long-headed biceps with the adjacent short head next to it. So you see this lovely kind of butterfly appearance where we have one normal healthy wing and a grossly abnormal atrophic wing here. So we have a chronic long-standing long-headed biceps rupture. And often these can happen and be relatively asymptomatic. And the reason the patient becomes asymptomatic is because of a bicipital vinculum, this little bit of fibrous collagenous tissue that sits in there analogous to the vinculum within the fingers and the flexors. So it's a bit of collagen that holds and approximates the tendon down towards the humerus, and it can hold the biceps tendon up relatively high, and you can have a minimally significant cosmetic defect. However, when your vinculum is disrupted, so if you rupture your long-headed biceps and the vinculum is disrupted as well, this is where your long-headed biceps retracts. So this is longitudinal, tracing down towards the elbow, and we're trying to find where our biceps muscle is. And here is our retracted bit of tendon and our distal stump of our long-headed biceps with our big hematoma in through here. So when you have a big drop of your biceps, it's sitting down, you get that textbook Popeye appearance. The vinculum is also disrupted with your long-headed biceps tendon. Now I'm going to introduce the biceps pulley concept. So the biceps pulley is this amassment of tissue, these capsular ligaments that envelop around the long-headed biceps tendon. And it consists of the coracohumeral ligament sitting on top and the superior glenohumeral ligament underneath. So it forms this pulley apparatus, and it kind of helps hold and support your long-headed biceps as it runs over the top of the humeral head. So more commonly it's referred to as the rotator interval, which is a lovely analogy. There's a beautiful article here that I've referenced to that really demonstrates both the sonographic and cadaveric anatomy of the rotator interval, where our coracohumeral ligament sits on top of our long-headed biceps up in through here, and it runs around and throws its fibers down towards the rotator cable and the capsule, and envelops over the top of supraspinatus, and also throws its fibers above and below the subscapularis, with our superior glenohumeral ligament sitting in the middle up in through here. So these ligament complexes, the coracohumeral ligament and the superior glenohumeral ligament, live up the top, support that biceps, and help to stabilize it as it runs over the top of the humerus. So the coracohumeral ligament, it envelops the whole of the subscapularis and envelops the whole of the supraspinatus, and it holds all in close proximity. So it holds subscapularis up and supraspinatus up and helps to support and stabilize the top of the humerus. So it provides superior posterior stability to the humeral head, as well as elongating the long-headed biceps. We can see it over long-headed biceps. We can also see its origin from the coracoid process. So we can see our coracoacromial ligament and our coracohumeral ligament running down to run over top, down in through here of the long-headed biceps. The other ligament that makes up a rotator interval is the superior glenohumeral ligament. So the superior glenohumeral ligament is one of the shoulder joint ligaments. It's an extension of the glenohumeral joint. It extends its fibers out, and it changes its shape and position as it comes out of a rotator interval. So we can think of a rotator interval as a pie shape. So it's thicker and broader at its proximal origin, and then tapers down to be thinner towards its more lateral component. So the superior glenohumeral ligament sits more medially to the long-headed biceps as its proximal position, and as it goes down it becomes the floor underneath the long-headed biceps. So we can think of our long-headed biceps as the passenger, and our superior glenohumeral ligament and our coracohumeral ligament as the passage. So the passenger and the passage analogy. And you'll notice that the superior glenohumeral ligament is chocked up medially, chocks the long-headed biceps up medially. So it holds the medial aspect of the long-headed biceps up to prevent that medial migration of the long head. So it props it up and holds it because it always wants to dive out medially. So why is this important? What's the importance of the rotator interval? Well, it's really important because this is where a lot of the long-headed biceps tendinopathy occurs, is up in the interval. It can be involved in rotator cuff tears. It's really important in biceps subluxation events, glenohumeral instability, and also in frozen shoulder, which Matt will elaborate on later. So in the setting of long-headed biceps tendinopathy, the tendinopathy occurs up within the rotator interval. That's where it occurs. It doesn't happen down in the bicipital groove. It occurs up the top in through here. So this is where you need to be investigating when you're having a look at your long-headed biceps, is up in the rotator interval. This is where your tendinopathy will occur. It can get damaged with rotator cuff tears. So here we have a subscapularis insertional tear, and we can see it's disrupted part of a coracohumeral ligament. So we've got our superior subscapularis tear, and the coracohumeral ligament is involved. Here we have a full thickness complete tear of the supraspinatus, which involves the rotator cable, and we can see that our coracohumeral ligament, we have a little stump of coracohumeral ligament up in through here. So our rotator interval is also disrupted with this full thickness cuff tear. And what happens here is it can lead to long-headed biceps instability. So if you don't have a rotator interval, the long-headed biceps can shake and rattle around over top of the humerus, and it causes it to become frictioned and irritated and quite cranky. And we know that the long-headed biceps is a big pain generator. So this can be the big cause of the patient's symptoms, is this long-headed biceps irritability. It also gets involved in the setting of frozen shoulder or adhesive capsulitis, is that the rotator interval and particularly the coracohumeral ligament component becomes thickened and hypervascular. Now we're going to talk about long-headed biceps stability. Okay, so the long-headed biceps should sit nicely in its groove. When it doesn't, when it tries to get out, it always tries to get out on its medial approach. It tries to get out medially. And the reason it gets out, wants to try to get out medially, is because its origin is medial and its insertion is medial, but it has to take a lateral course through the bicipital groove to wrap over and sit on top of the humeral head. So where we're going to be focusing most of our attention is on the superior aspect up here of subscapularis. This is where we're going to have most of our pathology. The superior fibers of subscapularis, involving the superior glenohumeral ligament and the coracohumeral ligament. So when we have a look at these disruptions, this is our most common form of biceps medialization, and it occurs because of a defect in the deep fibers of subscapularis. So you have a deep surface defect of subscapularis that allows the biceps to drift medially, but the interval is still intact. You can have an isolated defect of your superior glenohumeral ligament, which is very rare. When your long-headed biceps gets out of that groove, we know we've got a larger tear of the subscapularis, and also the superior glenohumeral ligament is deficient. When your long-headed biceps jumps out over the top, it's most commonly due to a defect in the coracohumeral ligament. When your long-headed biceps sits completely medially, we know we've got a full thickness defect of our subscapularis, which may involve the coracohumeral ligament, or may not. The coracohumeral ligament may be intact. So when we have a look at these cases, we can see our long-headed biceps sitting up and over top of our subscapularis, but subscapularis is nicely intact. So we know this one has an isolated defect of the coracohumeral ligament. However, when we have our long-headed biceps sitting very, very medial down in through here, so we have a completely medialized, a completely dislocated long-headed biceps, and here's the bicipital groove up the top in through here, we know we have a large defect. We have a complete tear in this setting of our subscapularis tendon. So our subscapularis is torn, and also our rotator interval. But more commonly, what we have are these little superior subscapularis tears. So we'll have a look up here with our subscapularis coming up and through. We have these enthesis-derived delaminations of our subscapularis, and it causes our long-headed biceps to drift medially. It loses that superior chock, okay, because the superior fibers of subscapularis and their blending of fibers with the superior glenohumeral ligament have lost that support of the long-headed biceps. It's not chocking it up medially, it's starting to drift out, so it's starting to medialize, and we're starting to get this tendinopathic long-headed biceps. So although all of this is very interesting academically, it doesn't often change the clinical management of the patient. So you can have these isolated tears or multi-structure tears of the rotator interval and subscapularis, but it doesn't tend to change things. The long-headed biceps gets irritated, it gets cranky, it gets irritable. And then we need to manage that patient, and that may be by rehabilitation, offloading, deloading exercises. The next step, if they fail that, is injection therapy, and this is where your ultrasound guided injections come in really nicely. So injecting that long-headed biceps up towards the rotator interval, and remembering that this is not only a peritendinous injection, this is also an intra-articular injection. So this is running into the glenohumeral joint as well. So you're doing an intra-articular but also extra tendinous injection of the shoulder and long-headed biceps. And if your patient does well out of this, but they come back and they don't respond as well as you want in the long-term setting, then often they end up with a long-headed biceps tenodesis, where you chop the long-headed biceps and you pin it down. So here's a sonographic appearance post-tenodesis. With now short axis, we see our suture material wrapping around our long head, and our long head being embedded down in through here. So here's our little anchor plug up midway up the humerus. So it gives a nice cosmetic result up in through here, and back in longitudinal, here's our anchor point down here into our humerus. Now we're going to briefly touch on the subscapularis. We've already spoken about it a little bit, but we're just going to extend on that a little bit. So we're going to have a look at the medial component, the anterior medial component of the rotator cuff. So both the subscapularis and infraspinatus, often there's small delamination tears, and they can be hard to see on ultrasound because they're delaminating in nature because of the multi-pennate nature of these tendons. So they can lose one finger of tendon, but the rest of it holds on in. So you can have isolated tendinopathy of your subscapularis, and I think the venue's actually got quite nice Doppler sensitivity. I think it's quite a nice platform for Doppler assessment of tendons. More commonly, as we've already discussed, you get these enthesis-derived delaminations. So we have a look at the enthesis footplate. We see the bony pitting out in through here, and our delamination of the collagen with a cranky long-headed biceps associated. And then you have your subscapularis complete tears or complete ruptures. So we've got our long head, we've got bursal fluid over top, and this is the setting of an acute subscapularis tear. We've got retraction back in through here of the proximal tendon, and nothing inserting in onto the foot plate out in through here. So this is an acute traumatic subscapularis tear. So they can be acute in nature, or they can be more chronic in nature, where you only have the inferior muscular component still attached, and the superior tendinous component is no longer there. So you don't have collagen in through here, you just have a bit of joint capsule lying underneath. The other thing that you can have with your subscapularis, which is quite important, and it can mimic the setting of frozen shoulder, is that you can get calcific tendinopathy. So hydroxyapatite deposition within your subscapularis gives the same acute symptoms as frozen shoulder. So loss of external rotation, a lot of guarding movements, not liking those quick transitional movements, and calcification in subscapularis is one of the differentials you should be considering, and it often responds quite nicely to ultrasound guided barbotage, which Matt will talk about in a minute. So for long-headed biceps tendon, to assess for long-headed biceps, we palpate, find our bicipital groove, and then put our probe straight on. So palpate, probe sits straight on. So we'll have a look in short axis first. So we find our long-headed biceps, we follow it down into the bicipital groove. We're going to follow it down, chase for biceps the whole way down towards its musculotendinous junction. We can see our pec major insertion in through here, and then it starts to form its muscle underneath. So we see our biceps long head form its muscle under the pec major insertion. We're going to follow our long-headed biceps up into the rotator interval. And you notice that the hand position is in a nice, neutral, relaxed position. It's a nice way to assess biceps. So palm up, hand in lap, palpate the groove, probe on, follow down towards the musculotendinous junction, under pec major into the muscle belly, and then back up. And as we follow up over the humerus, we need to fix for our anisometrophy, remembering that the humerus is a ball-shaped structure, and the long-headed biceps comes up and rolls over the top. So we're going to, as we bring our probe up, we roll our probe up to fix our anisometrophy. So our probe transitions and rolls up to stay perpendicular to the collagen fibers of the long-headed biceps. Now we're up in our rotator interval. And we can see our coracohumeral ligament sitting on top. We can see our superior glenohumeral ligament sitting below. And we can notice that the medial aspect of our superior glenohumeral ligament chocks the long-headed biceps up medially, so it holds it up medially. We can see the blending of fibers from the top of subscapularis going into that rotator interval. And we follow our biceps up as high as we can get, sometimes taking the arm into a bit of extension, into a bit of a modified cras position. We'll put it on a bit of tone. Sometimes it'll help you, sometimes it won't. So try around in a few different positions. So we follow up, and here we can see a really nice image of the rotator interval with our coracohumeral ligament sitting on top, our superior glenohumeral ligament sitting underneath. We can see our coracohumeral ligament bridging down, going underneath our supraspinatus, merging into the rotator cable, going on top, those fibers extending on top of our supraspinatus. Then we can see the top of our coracohumeral ligament running on top of subscapularis as well. So it envelops those tendons, holds them in. So nice assessment of our long-headed biceps and our rotator interval. We have a look here, just from that neutral, just relax that arm, neutral hand in lap position. We can appreciate the top fibers of our subscapularis. We can follow our subscapularis down towards its muscular insertion and up to the top to its true tendinous insertion up the top. As we get up the top here, we start to get into those top fibers of the superior glenohumeral ligament. This is where we want to look for the irregularity, the enthesopathy of the lesser tuberosity. Up in through here, this is where you're going to have your pathology. So we have a look at the enthesis of subscapularis. We have a look at it in a neutral position, and also in a little bit of external rotation. Have a look at the enthesis, and have a look at a lot more external rotation. So assess it in various degrees of tone. External rotation followed down, have a look at that enthesis footplate, and it's the top fibers where you want to pay most of your attention. Subscapularis in through there, relax it down. For your injection therapy, injecting your long-headed biceps up at the rotator interval. This is the nice way to do it, standing behind your patient. Grab your long-headed biceps around the level of the rotator interval or at the level of the bicipital groove, and bring your needle in from a posterior approach, coming on down, dropping on down at about a 30-degree angle, and you can nicely inject in through here, injecting around your long-headed biceps, and remembering that this is not only a tendon sheath injection, but it's also an injection into the glenohumeral joint. So it's a joint injection as well as a tendinous injection. That's for biceps, subscapularis, rotator interval, and biceps injection.
First off today, I'm going to talk about the supraspinatus tendon. When I'm discussing some of the pathology here, I'm going to be referencing John Jacobson's excellent book, Fundamentals of Musculoskeletal Ultrasound. So our supraspinatus tendon has a bursal surface, an articular surface, and an enthesis or a footprint. And this is kind of our third surface. So we have these lovely crescent-shaped fibers coming down to insert onto our footplate. What does that look like on ultrasound? Well, we can see these lovely fibular nature of our tendon with our collagen coming down and inserting onto our footplate. We can see our hyaline cartilage here. We have a little bare area of bone before we come into our footplate, our enthesis. And right at the bottom here, we can see it's a little hypoechoic here, and this is a little ultrasound artifact that I want to talk about because it's very common in musculoskeletal ultrasound. It's an isotropy, and an isotropy is a common artifact due to the linear nature of tendon and muscle fibers. These linear reflectors like sound to hit them at 90 degrees, and they will give a nice echo directly back. What happens if we hit one of those linear reflectors at an angle not 90, it will reflect away from the transducer and we won't receive an echo back, and this can leave us with this artifact where we have this hypoechoic appearance and it can mimic a tear. So when we're assessing tendons, we don't want to assume that this is a tear. We want to be able to see a tear from several different views. So I'm looking here, I can see this part of the tendon really nicely. Then I need to move my probe and I need to approach this part of the tendon from a different angle. This will allow us to get our echo back. And what we will see when we do that is we will see our lovely tendon fibers coming down onto the bone, and we'll be satisfied that this is just artifactual. So rotator cuff disease, it encompasses a broad spectrum of pathologies with an increasing incidence in age, and we'll touch on a few of those now. The first one being tendinopathy. Tendinopathy is an overload issue, and what we see is we lose, on ultrasound, we lose this fibrillar nature of the tendon, and we'll get this heterogeneous, slightly hypoechoic appearance. So it will look patchy and a little darker. And we'll also get some thickening of the tendon. You can see through here that thickening there. And then we'll move on to what happens next, which is commonly our tears. And this is an example of a partial thickness articular surface tear. So it communicates and touches our joint surface, but does not run through into our bursal surface. So we can clearly see tendon fibers going across there, but we communicate and touch the articular joint surface. What does that look like on ultrasound? So a little giveaway is we can have these little bony irregularities at that enthesis, and so this is a little giveaway that there's going to be a little tear there. So we can see this little tear in the deep fibers going over the top. Again, in our short axis view, we can see tendon fibers going over the top. So if we come down towards our footprint, we can see an undersurface tear and tendon fibers going over the top. Then we have our partial thickness bursal surface tears, where we have a tear which touches the bursal surface and communicates with the bursa, but does not extend down into our joint. So on ultrasound, again, we've got the advantage of having a little bony irregularity there to highlight our tear, and we can just see a flattening off of these fibers just through here. In our other view, we can just see these loss of fibers just across that bursal surface as we come down to the foot plate, much like this example below. Then we have our third type, our partial thickness intrasubstance. Now these tears will start at our enthesis and continue through the middle of the tendon, and they will not communicate with our bursal or joint lines. So they won't communicate through to our articular joint, and they won't go through to the bursa, so they'll just come through the middle. These are ones which obviously arthroscopically won't be able to be visualized, so we have to be confident in calling these. We can see here a little tear running through the middle. If we have a look at the video of that, we can see this tear running down. As we open that up in long axis, we can again see that tear running right through that tendon there. And then moving on, we have our full thickness tears, and full thickness tears allow communication of the glenohumeral joint with the bursa. So we will have direct communication and a tear running all the way through from superficial to deep. On ultrasound, what do these look like? Well, we have this retraction of the tendon, we have our empty coming into infra there, but as we come back onto supra, we have our empty enthesis, our foot plate, and we have this retracted tendon. Here it is here, coming up our tendon. As we come towards the foot plate, we have a loss of our tendon through here at the facet. A couple more examples. This is without as much retraction, but we can see this bony irregularity across the foot plate, and we can see a little bit of retraction and this clear communication of fluid through. That same patient in the other view, we can see it at that posterior supra, this tear through here. Couple of ultrasound signs to look for when we're assessing these tendons. First of all is our sagging peribursal fat sign. So as the supraspinatus retracts with a full thickness tear, the peribursal fat which sits over the top of it can sag into the space left by the tendon. And this is one to be careful of, because this fat has a similar echogenicity to the tendon and can sometimes be mistaken for tendon collagen. We want to clearly differentiate these fibular tendon to this just more bulky fat. We need to make that distinction, and also at times if we're injecting, we'll have that advantage of just putting a little injection in right nearby and watching the injectate run either side of that fat and highlighting that, not only that fat but our tendon a little better. So we'll see as we continue and get a bit more fluid, we can see that clear differentiation. Cartilage sign is another sign we look for. So as the tendon retracts and fluid moves into the space, we get quite a marked difference in acoustic impedance of the fluid and the underlying hyaline cartilage, and this allows us to have this very clean, thin, hyperechoic line which represents the cartilage surface. So we'll just play that. We see this cartilage surface here quite clearly. When we have tendon over the top there, it is not as obvious. So if you come through here, we can see find it hard to see, but as we get into where the fluid is, where the tendon has retracted from, we can see that hyaline cartilage really quite easily through there. So that's a nice sign to look for in a full thickness tear. One thing is we've focused a lot on the distal tendon. We want to make sure we scan the entire tendon. We don't want to miss a musculotendinous junction tear. So as we come down, we can see the footprint quite nice. As we come up towards that musculotendinous junction, we can see a clear tear through here. Let's play that again. Clear tear at the back there. And as we come down, it looks nice. As we come onto our long axis, we can see tendon fibers here, but we lose our tendon fibers through here, our musculotendinous junction. This is a musculotendinous junction tear and not to be missed. Also, our supraspinatus consists of two bundles, and our anterior bundle has this nice linear nature and comes directly down. But as we go towards our posterior tendon, it has this oblique nature, and it blends across with infraspinatus, and that means we can sometimes have these complex oblique tears. So we have this tear here, which we can see touches the articular surface here, but it also has this little oblique tear running up and through, communicating with the bursal surface there. So this is a oblique full thickness tear. So this is our long axis, and we can see, because we've got this full thickness tear, we can see this bursal effusion here as this joint fluid communicates through, and we can see this quite clear, distinct line coming up and through. And these are ones that we want to be very dynamic on. It's very hard to show these in one static image, so we want to be quite dynamic. We see quite a bit of fluid in the bursa on that long. As we move around, we'll talk about our infraspinatus, and we'll just talk about this facet anatomy of our greater tuberosity. So we have our superior facet with our supraspinatus, and that blends across and in with our infraspinatus on our middle facet. And as we come around the back, we have our inferior facet, and this is where our teres minor lives. So on ultrasound, we can see here's our biceps, this is our supra. As we come through the back, we can't have our infra blending over the top. So let's play that. We'll roll around to the back a little bit, and as we come down towards the insertion of these tendons, we can see this clear bony peak, and this is where we can distinguish our superior facet from our middle facets. This is our supraspinatus footprint, which is usually only about 12 or 13 millimeters wide, quite a lot narrower than we quite often think. And this is our infraspinatus coming through the back, and on this one we can see a little interstitial tear in our infraspinatus just here with this bone irregularity. Another little example showing those facet anatomy. So here we have coming down, and we'll just pause that there. So this is a great way of distinguishing which tendon's involved in the tear. So we can see supraspinatus involvement, but we can also see it extending into our infraspinatus behind. So we can see here this tear extending into infraspinatus involving both tendons. We just watch that again as we come down. We can distinguish both tendons being involved, and we have that marked bony prominence to distinguish that for us. Now, infraspinatus is a common spot for calcification. We can have degenerative calcification, which is more this thin, linear calcification that we see. It's often near the footprint, often associated with tendinosis, and it's something we're not too concerned about. And then we have our acute calcific tendinosis, and this is our true hydroxyapatite deposition. In its formative stage, it will be quite firm and have quite a distinct shadow. And in a resorptive phase, where we become more symptomatic, we often have no shadow and will quite often have reactive tendinitis or bursitis associated with it. And this is the one we're mostly interested in. So here we are here. We can see it. This is our long axis coming on the supra and back onto infra. We can see the flattening of that facet there, that middle facet with our calcium over the top. So we'll just have a look at that. Here's our biceps, here's our supraspinatus and our overlying tendon. So very much bicep, supra and our overlying infra. And if we have a look at that, we can see that the overlying infra is where that calcium is. So this is sometimes confused as posterior supraspinatus, but it's actually infraspinatus calcification overlying our supra. So what do we do when we see this calcification? Well, we love to get this calcium out of the body. And the best way of doing this is with our one puncture technique. So initially we might use a 25 gauge needle to put a bit of local anesthetic from skin down to bursal surface without touching our calcium. And then we'll use a larger gauge needle, an 18 or a 20 gauge needle, and we will advance that into our calcium, into the center. And why we do this is we want to build up pressure within this calcium. What we want is we want to push on our plunger, build up pressure within this calcium without rupturing it, and then release our plunger. And what that will do is the build up of pressure will then push our injectate, either our local anesthetic or saline, back up the needle and hopefully wash with it a bit of calcium. And we repeat this process of building up pressure and releasing, and we just keep pumping the plunger and just washing out this calcium and decompressing. Sometimes we may need to change syringes for a clean injectate as required as it builds up, because as we can see, we will quite often build up quite a healthy bit of calcium in the syringe, and we don't want to keep recirculating that. So we may change syringe as we go. And once we're happy we've decompressed the calcium, we will just withdraw the needle into the bursal space and just inject some cortisone to settle down that reactive bursitis we'll no doubt have as we've washed not only this calcium out into the syringe, but undoubtedly a little bit will go into the bursa as well. We'll touch on our teres minor. So here we have, this is our long axis down the humerus at the back here, and we have our middle facet with our infraspinatus, and this is our inferior aspect with our teres minor. We'll just play that video, and our teres is quite tendinopathic there. Uncommon to have a lot of issues with teres. This patient had a tear of his infra, and that was quite an atrophic muscle belly we just saw. We'll discuss the assessment of the muscle bellies in our live scanning, but we have this quite tendinopathic teres insertion here. This is the long axis of that insertion. We'll touch on our subacromial subdeltoid bursa a little bit. So we see a lot of bursas being measured for that thickness, so that they're allowed to adaptively thicken it, and this isn't a really good guide of bursitis. A large majority of our patients with bursitis it will be a consequence of issues with the underlying tendon and that peritendinous inflammation we see. So that's why we're going to mainly focus on the tendons with this talk. What does a true bursitis look like? Well, we'll have this synovial proliferation, we'll have quite a effusion, and we will have marked hyperemia around the edges. And when we see this, we're straight away thinking of a systemic inflammatory condition, particularly if we have this amount of fluid and no obvious full thickness tear anywhere in the cuff. So we love to inject things. When we're doing our bursal injections, we want to, again, a needle, just the same as a tendon, is quite a linear reflector. We don't want to have a steep needle angle. So when we start our approach with a needle, we want to start a couple of centimeters away and come in at a flatter angle. So here's our needle here. This is on our trapezoidal Van view, and we can pop that into that bursa. And this is what we want us to see, is we want to feel not too much pressure. We want that injectate running away from the needle tip. So this is 5 mils of injectate just running away freely. If we see that blotching and collecting in the tissues, we're probably not in the correct position. We just need to readjust. So as long as it's running away nice and freely, we know we're good. This is with our lovely needle guidance on, where we can get a little bit of needle gain really to highlight it. Probably coming in at this shallow angle, not required, but it does highlight that needle really nicely. Again, we can see that injectate running away. Another nice example, just showing that needle nicely shown with that lovely angle. I'm going to be discussing the supraspinatus and infraspinatus and their facet anatomy. And our landmark to find our supraspinatus is our bicipital groove. So we're going to palpate for that and start at the front and find our biceps through the groove. As I go posterior, I'll come onto our supraspinatus. Now, to bring that supraspinatus out and into our view from under the acromion, we're going to go into our modified Cras position. So hand on hip, elbow in. And we'll locate our bicipital groove again, and there we are falling onto our supraspinatus. Now, to know I'm in a true short axis plane, I just want to scan through, and I want to make sure I'm not falling off the cartilage as I am here at the back and not at the front. So I'm just going to adjust my probe position so I'm in a true short axis. And the humeral head is spherical. What we want to do is, as we're scanning down towards the origin, towards the insertion of the supraspinatus, I just want to roll my probe around so I can get a look all the way through there. So I can see that all the way through, looking really nicely. Excellent. Then it's a simple, just turn 90 degrees from that position, and I'm into my long axis. And again, I want to find my bicep so I know where our anterior supraspinatus is. So I'm going to fall anteriorly until I come off the supraspinatus and there onto the bicep. So as I come back posterior, I know I'm on anterior supra. So you can see here the insertion of the supraspinatus is quite hypoechoic, and this is our anisotropy. So I need to change my probe position, move a little more laterally and angle in to show those fibers coming down onto that footprint. You can see that really nicely through here. So this is important that we change our position and look from more than one position. So this is the modified Cras position. We also have our Cras position where we get our patient's hand right wrapped around and into the small of the back. I find it can pull the biceps a little bit too far forward, and I actually am losing that anterior supraspinatus. I don't find it as effective, and it puts it a little bit more on tone. We want it a little off tone, a little relaxed. So that's that modified Cras. Now, to assess our facets and to recognise our supraspinatus and infraspinatus footprints, we're going to use our facet anatomy. So I'm going to scan laterally and come down onto the insertion. And you can see this little bony prominence here in the middle, and that is separating our superior facet from our middle facet. So our supraspinatus from our infraspinatus. And this is a way of defining which ligament, which tendon we're on. So we use that little bony prominence there. So is just simply as scanning down our supraspinatus, find our bony prominence moving around. So supraspinatus and infraspinatus there. I can also appreciate this in our long axis. So we can see this nice sloped footprint here of our supraspinatus, but as I come posterior, we'll see that start to flatten out. And this will be our infraspinatus. You can see that flattening of that footprint there, and we can see these striated tendon coming through. And that is our infraspinatus with our tendon coming off on another view. And I find this is an excellent way of assessing our infraspinatus and not trying to stretch our hand across. So this is an excellent way of assessing our infraspinatus insertion. So then we can go on our true long axis of that infraspinatus. We can get an excellent look through there. So that's how we assess those two tendons. We're going to touch on bursa and our bursal injection. So I like to have the patient as relaxed as possible, but we also need to make it as easy for ourselves. So we'll have the elbow back a little bit. We'll have our short axis view, and we will go in from a posterior approach. And again, we won't be right at the edge of the transducer. We'll come back a couple of centimeters and come in a little flat and glide into that top of the bursa, and we want to see that fluid flowing away, and we don't want to see it puddling up. So that's how we do our injections.
The acromioclavicular joint is composed of a capsular joint, and it involves its stability from the coracoid with its coracoclavicular ligaments of the trapezoid and conoid ligaments that help to stabilize and hold the clavicle down onto the coracoid process and stop instability of that joint. So investigating AC joint injuries with ultrasound is relatively easy. So in your grade 1 injuries, so if we use our Rockwood classifications, sonographically they're hard to tell the difference between a degenerative AC joint and a traumatic AC joint. The easiest way is to get a good clinical history. So sonographically, degenerative and grade 1 injuries present exactly the same, where you get a bit of irregularity of the capsule, but it's grossly intact and often a bit vascular. Grade 2 injuries involve disruption of the capsule, but the coracoclavicular ligaments are still intact. So the capsule is disrupted, you start to get this more gapping of the joint as you horizontally flex or weight bear through their arm. The joint gaps, it opens up, but it doesn't move a great deal, and the coracoclavicular ligaments are still intact. When you have a grade 3 AC joint, when you have complete separation of a joint, the coracoclavicular ligaments are torn, and we often see bony stripping associated with these. And they present clinically like this, they present on X-ray like this, and they present on ultrasound exactly the same. You don't need ultrasound for a grade 3 AC joint injury. Degenerative AC joints, the capsule thickens up, you get a loss of joint space, you get a bit of irregularity, and as you horizontally flex and extend, the clavicular end and the acromial end abut each other. They push together as there's a loss of joint space. They milk out the fluid in between. They're often a bit vascular, so the capsular component is vascular running down within the joint itself, within the synovium. You can get AC joint ganglions, which are not uncommon. So little parajoint ganglions that sit up the top. They can give little painful lumps on the top of the AC joint and often respond quite well to injection therapy. But one thing not to miss is osteolysis of the distal clavicle, especially in your young, fit, athletic weightlifting population. So distal clavicle osteolysis is really a subchondral insufficiency fracture of the distal clavicle. Okay, so it's not avascular necrosis, it's an insufficiency fracture. So it's a repeated stress fracture of the distal clavicle. And this happens when people overload it. So it's your large weightlifting patients most of the time, or your gymnastic population who do a lot of weight bearing through their upper extremities. So it's a pathological destruction, disappearance of bone, and resorption of bone, resulting in instability. And so it's this stress fracture that results in early osteoarthritis. So when you see this irregularity down within the intra-articular component of the distal clavicle. One thing not to forget is that the AC joint, just like any joint, can undergo crystalline arthropathies. We've got gout deposition within the lining of it, so you see the echogenic crystals within the lining of it. It's hot, it's vascular. But not only gout, you can also get pseudo-gout, so your calcium pyrophosphate deposition disease. So you get your calcium pyrophosphate that lives within and sits on top of the lining of the cartilage. So you see your bone, you see your cartilage, and you see your crystalline arthropathy sitting on top. When we inject the AC joint, it's a very easy joint to inject under ultrasound. I really like a short axis approach and injecting posteriorly. So scan short axis on the joint, you find your joint space and you introduce your needle posteriorly. So you introduce your needle between the acromion and the clavicular, so you needle the whole way through, you inject, and you fill up that joint space. So a nice full AC joint post-injection. A very easy injection to do under ultrasound guidance. The acromioclavicular joint, again, palpate, probe on. So we line up and we see our clavicle and our distal acromion. We assess the joint capsule, we scan anteriorly, we scan posteriorly. So we go the whole way through that joint, from the front to the back. We assess what's happening at the bony morphology of the distal end of the clavicle, assessing for osteolysis. We assess the capsule for irregularity if it's post-trauma or degenerative. To assess the stability of our AC joint, we can take our arm up into forward flexion and horizontal flexion and horizontal extension. And we have a nice stable AC joint. We can also have a look in weight bearing. So just put your hand on the chair there and just push in through there, good, and relax. And again, push through that arm, lift your bottom up and relax. We have a nice stable AC joint. Relax that in your lap. From an AC joint in long axis, we can also assess it in short axis. So as we get in through here, we're now short axis on the joint in through here. We see that circular nature of the joint. We see our rotator cuff sitting down below. As we fan our probe more medial, we're on the clavicle, and as we get lateral, we're on the acromion. So we're now short axis in the joint, and this is a lovely way to do our joint injections. Just move the cord out of the way here. So you'd sterilise your area, go short axis on the joint because we know we're in the joint, and then bring your needle in from about 1 centimetre down and a pretty straight approach, and you get a nice little AC joint injection. Very nice way, very quick and easy way to do an AC joint injection. So find your clavicle, find your acromion, in the middle, see the joint in short axis, drop your needle in.
With the glenohumeral joint, we're just going to touch on a couple of pathologies we see. So ultrasound isn't too bad at all at looking at osteoarthritis, so we can see anything from this early bony proliferation at the edge of the articular cartilage to these larger caudal osteophytes that we see in advanced stage. So what we need to do is we need to make sure we scan the entire superior to inferior portion of that glenohumeral joint from a posterior approach, and we want to even extend our visualization down inferiorly off the joint. Another little example to show why we need to extend our view is this is coming down inferior, and this is a little labral cyst extending into the quadrilateral space. And if we're not careful and just looking for a nice view of our humeral head and glenoid, we will miss this. So we want to scan superior and all the way inferior and through the joint. One big topic I want to talk about is frozen shoulder. So frozen shoulder clinically, our early stage, we have a patient presenting with this diffuse pain, often worse at night, quite often increasing through the first few weeks. We get pain at the end range of movement. They still have generally full movement, but pain right at the end ranges, they're just stretching that capsule, and we get pain with sudden movements when they go to reach out suddenly to catch something. As the disease progresses, that's when we start to see this global reduction in our range of movement. Sonographically, we have a few features that we will touch on that we can see. So after getting a good clinical history, the first thing we tend to look at with our shoulder is our biceps, and we'll quite often see with a frozen shoulder a small biceps sheath effusion. So this is a nice little soft sign. And whilst we're at the front, we have the opportunity to look and see if we can identify our coracohumeral ligament. And we'll show you how to see that later. But we will look for a thickened coracohumeral ligament running through, and we'll look for any edema in the tissues around. We may even see a bit of hyperemia in those tissues. We can also assess the rotator interval, looking for any increased blood flow, hyperemia through there, and any thickening. And this is basically because it's our continuation of our coracohumeral ligament. So as we come across from our coracohumeral, we'll see that increased vascularity quite often all the way through into that rotator interval. And finally, but most importantly, we're looking for our thickened glenohumeral joint capsule. So just like our MRI images, we want to see this thickened capsule. So this is our posterior glenohumeral joint. And we can see straight away there's a little bit of thickening of that capsule, and as we drop down to extend down and we're getting into sort of our humeral neck, we can see that thickening wrapping around onto that humeral neck there, much like this image above. If you think of this view through here, this thickening right against the bone. The best way of looking at our glenohumeral joint is via the axilla, and we'll show you how to get this image later. But our inferior glenohumeral joint recess is an excellent and relevant finding for frozen shoulder. So there's been a few studies regarding this, and they have thicknesses of anything to 2 to 3.2 millimeters to assume it's pathological. Now, a lot of this relies on particular arm position, and also exactly where they're getting the measurement. I think the important thing is to be consistent in your measurements, and it's excellent to be able to compare if we have an asymptomatic healthy side. So in this case, we have clear thickening. It's over 3.2, quite obvious thickening, and we can see some swelling of the overlying tissue, some pericapsular inflammation. And here's our normal side with our nice thin capsule. Another example, this one's not measuring as thick, but I tend to measure the capsule, and if I was to measure that right off the bone, as the studies do, it would no doubt be over the threshold. Of course, I'm being consistent, and I can see from our normal to our abnormal a marked increase in our thickness, and also I've got the patient in front of me, I'm able to speak to them. So biceps tendon sheath effusion is a nice soft sign, and then if we can, we're looking at our coracohumeral and rotator interval when the patient's movements and allow us, but most importantly, we want to really try to assess that glenohumeral joint, particularly from the inferior approach. And most importantly, we need to clinically correlate these findings to ensure our frozen shoulder diagnosis. When we see a frozen shoulder, we are very keen to inject. We want to try to reduce this inflammation. We don't want to stretch the capsule, particularly in the early stages, but with a large volume hydrodilatation, we just want to introduce some corticosteroid. So we will tend to approach from a lateral approach and just slide our needle just along the edge of the cartilage into the back of the joint. Once again, same as our burst, so we want to see that injectate running away freely and filling the joint. We don't want to see it pooling in around the labral tissues or the muscles at the back. Here's another one with our needle guidance. We can see our needle coming in. We can see a nice line injecting, and we're not seeing any pooling of that fluid and that injectate, so we know that's running away nice and freely. Thank you for joining us. Dan and I really enjoyed this speaking to you. You can find us at mskaustralia.com.au and check us out and follow us on Twitter. Thank you. So I'm going to have a look at the posterior glenohumeral joint. So the way we find this is we palpate for the spine of scapula, put our transducer on just inferior to that, and we just angle down inferiorly from there. And I'm going to just angle that medial edge of my probe inferiorly just to get a nice little plane through that glenoid and humeral head. And there we are, we've got our glenoid, labrum, our humeral head with its articular cartilage. And I want to assess the full superior to inferior aspect of this glenohumeral joint. So I'm going to fan up as far as I can, and then I'm just going to slide my probe down all the way through the inferior joint capsule and beyond, just to make sure there's no labral cysts off the bottom. So we can see we've assessed there the whole way through. I've got the hand in a really nice neutral position. If we want to reach the hand across the body, we find that that will push those muscles and stretch those muscles across the back of the capsule, and will push that joint fluid away. So we like to see this in a nice neutral position. The way we inject is we move and have our joint in the middle, and what we do is we come in from our lateral approach after we've sterilised the skin and just drop down next to, and what we do is we want to drop down and into the joint capsule from this side. We can also use if we want to inject into the joint, approach through our bicipital sheath at the front. So once we've assessed the back of the joint, we also want to assess our inferior joint capsule. So what we'll do is we're just going to slide our patient around. I'm going to get the patient's hand on their head in a nice relaxed position. So if they can produce that, get a little extra probe on, extra gel on my probe, and all I do is as simple as eyeballing, getting the line of the humerus and just putting my probe on under the arm and just a little back and forth, and we'll just find our humeral head and line up, and again just scanning through, assessing the entirety. And we want to be able to see that capsule coming over that articular cartilage and down through into the neck there. So that's a nice simple way of looking at through our inferior joint capsule.